Good morning, everybody. This is Chapter 6, Bones and Skeletal Tissues. So before we start, I just want to make an announcement that, or to reiterate, that the assignments, the quizzes, and homework were due at the exam, and if you hadn't done them, I put zeros in. However, you do have until December 16th to complete those missing assignments and get them in without penalty. Okay, so I just want you to know how your grade looks currently with those assignments in, and then you can work towards completing them by the end of the semester. But please don't procrastinate. The earlier you do them, the better. Once again, the homework and quizzes in Canvas are due December 16th. All of them. But zeros will go in at each exam for the corresponding chapters. Okay, so we're talking about bones and skeletal cartilages. So the human skeleton initially consists of just cartilage, but then it's replaced by bone, except in certain areas. And so the basic structure is skeletal cartilage made of highly resistant cartilage consisting primarily of water. There's no blood vessels or nerves. There is a perichondrium, which is a dense layer of tissue around the bone, and this helps it resist outward expansion, as well as contains blood vessels for nutrient delivery to the cartilage. So the cartilage is made up of chondrocytes. Chondrocytes are what make the cartilage. And these cells, these chondrocytes, live in small cavities called lacunae. So there are three types of cartilage. There's hyaline cartilage, which provides support, flexibility, and resilience. This is the most abundant type. It contains collagen fibers only. You find hyaline cartilage in the articular joints, the costal ribs, the respiratory, like the larynx, the nasal cartilage, like the nose tips. Then we have elastic cartilage, which is similar to hyaline cartilage, but contains elastic fibers. These are seen in the ear and the epiglottis. And then fibrocartilage. This thick collagen fiber has great tensile strength, and this would be found in the meniscus of the knee or the intervertebral discs. So cartilage grows in two ways. There's oppositional growth and interstitial growth. In oppositional growth, cartilage forming cells in the perichondrium secrete matrix against an external face of existing cartilage. So they lay down a new surface of cartilage. With interstitial growth, the chondrocytes within the lacuna divide and secrete their matrix, expanding the cartilage from within. And so this is new cartilage made from the matrix. So calcification of cartilage occurs during normal bone growth, but also in old age. It is hardened with old age. So there's 7 important functions of bones, and I would put these all on flashcards. Support, protection, movement, mineral and growth factor storage, blood cell formation, which is hematopoiesis, fat storage, hormone production. So these are 7 functions of bone. There are 206 bones in the adult skeleton. The skeleton is divided into an axial skeleton, which is the long axis of the body, the skull, the vertebral column, the rib cage. Then there is the appendicular skeleton, which is the bones of the upper limbs, the lower limbs, and the pelvic girdle. So that would contain the arms, the legs, and the pelvis. As we classify our bones, we've got long bones like the humerus and the arm. They're longer than wide, and these are limb bones. We've also got short bones, cube-shaped bones in the wrist, like the carpals and the ankles. We've got sesamoid bones from within, like the patella, within tendons. We've also got flat bones, thin, flat, slightly curved. This would be the sternum, the scapula, the ribs. Most skull bones are flat bones. And then we have irregular bones, which are just more difficult to characterize. These are like the vertebrae or the hip bones. So bone is made up of compact and spongy material. So the compact bone is the dense outer layer on every bone that appears smooth and solid. The spongy bone is honeycombed, and there are these pieces called trabeculae, which are needle-like or flat pieces of bone, and they create open spaces where the marrow, whether it's red or yellow marrow, resides. So flat bones consist of a spongy bone sandwiched between two thin layers of compact bone. And these can be short, they can be irregular flat bones. They consist of thin plates of spongy bone covered by compact bone. There's a periosteum, which covers the outside of the compact bone, and an endosteum, which is the internal portion. And in the internal portion, the endosteum, you can see these trabeculae of the spongy bone. And this trabeculae is going to house the marrow. Now, looking at a long bone, like the humerus of the arm, there is a typical structure, but we can see articular cartilage at the distal end near the proximal epiphysis. The other end of the bone is the distal epiphysis, and the middle of the bone, the shaft, is the diaphysis. So in the proximal epiphysis, there is a group of spongy bone and then an epiphyseal line, followed by more spongy bone. If you go a little deeper, you see the medullary cavity lined with what's called endosteum. Now the bone itself is circled by periosteum. So the bone grows at the epiphyseal plates, and then at maturity these epiphyseal plates will fuse and no longer grow. So there are two membranes in the bones. There's the periosteum and the endosteum. The periosteum is this white, double-layered membrane that covers external surfaces except for the joints. So it's a fibrous layer, and it consists of these Sharpie's fibers that secure to the bone matrix. There's also an osteogenic layer, and osteogenic means bone producing. So these are going to be stem cells that are osteogenic. They give rise to more bone cells. There are also many nerves and blood vessels that continue to the shaft through the nutrient foramen openings. And there are anchor points for tendons and ligaments. So we've got the endosteum on the inside and the periosteum on the outside. These are our two membranes. The endosteum is a delicate connective tissue membrane covering internal bone surface. Covers the trabeculae of the spongy bone. It lines the canal of the compact bone, and it does contain some osteogenic precursor cells. Red marrow has hemopoietic tissue in it. This hemopoietic is blood-derived tissue that these are cells that can produce different types of blood cells. In newborns, the medullary cavity, it contains all red marrow, but in adults, some of the red marrow can convert to yellow, some of the yellow can convert to red in different situations. Okay, markings. So the markings of the bone, and interestingly enough, a baby's bone, like the humerus, would be very smooth, whereas an older person's bone would have a lot of markings on it. And this is from tendon attachments, attachments of muscles that pull on the bone and create these little defects in the bone. So there are a few different bone markings. There's a projection, which is outward bulge, maybe due to increased stress from the muscle pull. There's a depression or a bowl, which is a groove-like cutout that can serve as passageways for vessels or nerves. And then there are openings, holes or canals in bones that serve as passageways for blood vessels and nerves. Okay, a little bit more on bone markings. So a tuberosity is a large rounded projection that may be roughened. The crest is the narrow ridge of the bone, usually prominent, like this iliac crest. And here we've got an ischial tuberosity. We've got a trochanter, which is a very large, blunt, irregular shaped process that we can see on the femur. And so here's the trochanter with the intertrochanteric line. We've got a tubercle, which are small, rounded projections or processes, an epicondyle, which is a raised area above the condyle. So here we've got the femur, condyle at the bottom, and this marking right here is the medial epicondyle, and this would be the lateral epicondyle. So more on bone markings. The bones that form joints have a head, a facet, and a condyle. So the head is the bony expansion right on the neck. The facets are smooth, nearly flat, articulate joints. And then the condyle is a rounded articular projection which will articulate with a fossa. There are also grooves, which are furrows, or fissures, which are narrow like slits, foramen, which are round or oval openings, notches, which are indentations, meatus, a canal-like passageway, sinus, cavity within the bone, and fossa, a shallow basin-like depression in the bone, often serving as an articular site. So what are the major cells of the bone? So there's 5 major cells. There's the osteogenic cells, osteoblasts, osteocytes, bone lining cells, and osteoclasts. So let's just go through these. The osteogenic cells are also called osteoprogenitor cells. Okay, so these are bone cells that are coming from stem cells. They're progenitor, so they're not quite bone cells yet. They're mitotically active in the periosteum and the endosteum, and they will differentiate into osteoblasts. Now, the osteoblasts are bone-forming cells that secrete the osteoid, and the osteoid is made mostly up of collagen and calcium-binding proteins. Collagen makes up about 90% of bone, and so the osteoblasts are active mitotically. So here we have an osteoprogenitor cell, which is a stem cell, which will differentiate then into the osteoblast. Osteoblast is the matrix synthesizing cell responsible for bone growth. Then we have the osteocytes. These are mature bone cells. So they're osteoblasts that have matured in lacunae, these are these little closets or holes in the bone, and once they're in their lacunae, they no longer divide. They are resident in that lacunae. So, and the bone matrix acts as a stress or strain sensor. So, the osteocytes respond to mechanical stimuli such as increased force, weightlessness. They communicate with the osteoclasts, and we'll get on that later. There's also bone lining cells. So on the external bone surface, there's periosteal cells, and on the internal, there's endosteal cells. So these help to create a lot of the matrix. Osteoclasts. So osteoclasts are derived from the same hematopoietic stem cells that become macrophages. And so osteoclasts are not the osteocytes. Okay? They are a different lineage. They come from the immune system. They're much more closely related to macrophages. And they're, when active, the cells will act in resorption of bone. So we've got an osteoblast that differentiates into an osteocyte that produces bone. Then we've got a separate cell, an osteoclast, which comes from white blood cell lineage, which is actually going to reverse what the osteocytes does, and it's going to resorb the bone. Here is a lacunae showing an osteocyte in the lacunae. They're no longer dividing. All right, so let's look at the microscopic anatomy of bone. So compact bone is also called lamellar bone, and it consists of an osteon, which is also called a Haversian system. These have canals and canaliculi. There's interstitial and circumferential lamellae. The osteon, or the Haversian system, is the structural unit of compact bone, and it consists of an elongated cylinder that runs parallel to the long axis. It acts as tiny weight-bearing pillars, and an osteonic cylinder consists of several rings called lamellae. These lamellae contain collagen fibers that run in different directions. They withstand stress and twisting. And so here we've got this, looks like a central canal with arteries and nerves and veins. And then these concentric lamellae, they're different directions that cover the central canal with these very thick and twisted collagen fibers. There are also perforating canals called Volkmann's canals, which line the endosteum and at right angles allow certain blood vessels and nerves to enter the periosteum, enter the medullary cavity, and enter the central canal. So the lacunae are small cavities that contain the osteocytes. Canaliculi, however, are hair-like canals that connect the lacunae to each other in the central canal. And when the matrix hardens, the cells are trapped. They trap the canaliculi from forming. Okay, here's some microscopic anatomy, interstitial and circumferential lamellae. And so we've got our interstitial lamellae, which are not part of the osteon. Here is our full osteon. So some fill gaps between forming osteons. Others are remnants of osteons that have been remodeled. And you can see circumferential bands. These are circumferential lamellae. They're deep to the periosteum, but superficial to the endosteum. Now these circumferential lamellae extend the entire distance of the diaphysis, and it helps bone to resist twisting, or to twist a little bit without breaking. And so here we've got an osteon, we've got our central canal, our circumferential lamellae, our lacunae with our osteocyte in there. All right, just a little bit on spongy bone. It appears poorly organized, but it's actually organized on lines that reduce stress. There are trabeculae, like cables, on a suspension bridge, which confer strength. So the spongy bone has no osteons, but the trabeculae do contain irregular arranged lamellae and osteocytes interconnected by canaliculi. There are capillaries in the endosteum that supply the nutrients. So bone is made up of organic and inorganic compounds. The organic compounds are the osteogenic cells, the osteoblasts, osteocytes, bone lining cells, osteoclasts, and the osteoid. Osteoid makes up 1/3 of the organic bone and is secreted by the osteoblasts. Now the organic components are going to be collagen that can stretch and stress. The inorganic compounds are called hydroxyapatites. These are mineral salts. These make up 65% of the bone mass. They're mainly calcium phosphate crystals around collagen fibers, and they're responsible for hardness and resistance to compression. So ossification, or osteogenesis, is a process of bone tissue formation, and it begins at month 2 of development and goes postnatal until early adulthood. But bone remodeling occurs all the lifetime. So different kinds of bone development. We've got endochondral ossification, intramembranous ossification, and endochondral ossification again. So I will review these. So endochondral ossification is when bone forms by replacing the hyaline cartilage. The bones are called cartilage, endochondral bones, and they form most of the skeleton. Then there's intramembranous ossification, where the bone develops from fibrous membranes. These bones are called membrane bones. A little bit more on endochondral ossification. Forms essentially all bones inferior to the base of the skull except for the clavicles. And these begin, the development begins in month 2 of development in utero, and uses a hyaline cartilage model, where it's going to just record over this model the bone. Requires the breakdown of hyaline cartilage prior to ossification. And it begins at primary ossification centers of the shaft, where you have the blood vessels that have infiltrated the perichondrium, converting it to periosteum, as well as mesenchymal cells that differentiate into osteoblasts. So there are 5 main steps of ossification. There's bone collar forms around the diaphysis of the cartilage model. The central cartilage in the diaphysis calcifies, then develops cavities. The periosteal bud invades cavities, leading to formation of spongy bone. The bud is made up of blood vessels, nerves, marrow, osteogenic cells, and osteoclasts. So the 5 main steps in this process of ossification, I'm going to go through a couple of them here. There's the diaphysis elongates, and the medullary cavity forms. And then there's secondary ossification centers appear in the epiphysis. And then the epiphyses ossify, with hyaline cartilage remaining only in the epiphyseal plates and articular cartilage. So let's take a look at this figure. So this is endochondral ossification in a long bone. So you start with a hyaline cartilage model. This has been laid down, and you wind up with a long bone with a nice diaphysis and 2 diaphyses and long epiphysis. So what happens is the hyaline cartilage, the ossification centers start to form, and blood vessels are numerous to support this structure with nutrients and other stem cells. So after the formation of the medullary cavity, there's the diaphysis is formed, the epiphyseal plates, as well as spongy bone at each epiphysis. Then there's a layer of articular cartilage that is laid down on each end. Okay, so that was endochondral ossification. Now let's go to intramembranous ossification. Begins with fibrous connective tissue membranes formed from mesenchymal cells. And this forms the parietal, the frontal, the occipital, temporal, and clavicle bones. These are your flat bones. So there are four major steps involved. These ossification centers are formed when mesenchymal cells cluster and become osteocytes, which we see here. The osteoid is secreted and then calcified, and so we see the formation of this bone structure where we've got our osteoblasts on the side for remodeling our osteocytes, which is making the osteoid. Woven bone is formed when osteoid is laid down around blood vessels, resulting in trabeculae. And there's an outer layer of woven bone that forms the periosteum. There's also lamellar bone that replaces woven bone, and your red marrow appears there. So there are four steps in intramembranous ossification. There's the ossification centers develop in the fibrous connective tissues, the osteoid is secreted and calcified, the immature spongy bone and periosteum form, and then the compact bone replaces immature spongy bone just deep to the periosteum, and the red marrow develops. What about postnatal bone growth? So, long bones grow lengthwise by interstitial or longitudinal growth at the epiphyseal plate. Bones increase thickness through appositional growth. Bones stop growing during adolescence. Some facial bones continue to grow slightly through life, like the jaw. Interstitial growth requires the presence of an epiphyseal cartilage in the epiphyseal plate, and the epiphyseal plate remains relatively thick, and the epiphyseal plate, let's take a closer look at it, but there's a resting zone, which is quiescent, a proliferative zone, which is growth, a hypertrophic zone, which is overgrowth, calcification zone, and an ossification zone, which would be the osteogenic center. So the resting of the quiescent zone is an area of cartilage on the epiphyseal side of the epiphyseal plate that is relatively inactive. There is a proliferative zone, which is the area on the diaphysis of the epiphyseal plate that is rapidly dividing. And these are pushing upward, elongating the bone. There's a hypertrophic zone, an area of older chondrocytes closer to the diaphysis, and the cartilage lacunae enlarge and erode, forming interconnected spaces. There's also a calcification zone surrounding the cartilage matrix. Chondrocytes die and deteriorate and form as calcification. There is an ossification zone where the chondrocytes deteriorate, leaving calcified cartilage at the epiphyseal-diaphyseal junction. This is ultimately replaced by spongy bone, and the medullary cavity enlarges as spicules are eroded. So growth in length of a long bone occurs at the epiphyseal plates. Here we've got an X-ray showing an epiphyseal plate. And we've got the resting zone, the proliferative zone, hypertrophic zone, calcification zone, and ossification zone. And this is how growth is going to occur in these long bones. Proliferation of these stem cells and hypertrophic growth of these cartilage cells, calcification, laydown, also from cell death, and then the ossification zone is where the new bone is formed. So growth in length of a long bone. So near the end of adolescence, the chondroblasts divide less often, and the epiphyseal line thins. Then it's replaced by bone, and there's no longer any growth at the epiphyseal plate. The epiphyseal plate closes, and the epiphysis and the diaphysis fuse. Females, this occurs around 18, and males, this occurs around 21. Bone does widen and thicken in response to weight, but it will not lengthen at the epiphyseal plate because that has fused. Okay, so during youth, let's see, we've got our epiphyseal line, we've got bone growth in length. Once it is reaches maturity, there is the epiphyseal line is fused, but the bone will grow in girth with adulthood by appositional growth or stresses and strains. What about bone growth and hormonal control? It is under hormonal control. So growth hormone is the most important hormone in stimulating epiphyseal plate activity. And this makes sense because growth hormone makes people taller, and that would stimulate the epiphysis to create new bone. The thyroid hormone modulates activity of growth hormone, ensuring proper proportion. Now, testosterone in males and estrogen in females at puberty promote bone spurts, and these will end as the epiphyseal plate fuses and closes. But then bone is remodeled. About 5 to 7% of bone is recycled each week, and so you've got your spongy bone replaced about every 3 to 4 years, and your compact bone replaced about every 10 years. So bone remodeling consists of bone deposits and bone resorption. This occurs to the surface of both the periosteum and the endosteum. And there are these remodeling units, which are packets of adjacent osteoblasts and osteoclasts, which coordinate the remodeling process. So let's take a closer look. So reabsorption or resorption is function of osteoclasts. They dig depressions and grooves as they break down the matrix. They secrete lysosomal enzymes, and the osteoclasts also phagocytize demineralized matrix or dead osteocytes. They break them down. Then once reabsorption is complete, the osteoclasts will undergo apoptosis, which is programmed cell death. So they've completed their mission. They now need to disappear, so they commit suicide and disappear. Now, the osteoclast activation involves parathyroid hormone and immune T cell proteins. So new bone matrix depends on the osteoblasts. So the osteoid seam is a band of unmineralized bone matrix that marks areas of new matrix. There's a calcification front, which is an abrupt transition zone between osteoid seam and older mineralized bone. Then there's a trigger for a deposit for not confirmed, but may include mechanical signs, increased concentration of calcium and phosphate for hydroxyapatite formation, matrix proteins, as well as some enzymes for mineralization. Let's continue for hormonal control. So there's a negative feedback loop that controls the calcium levels. So calcium functions in many processes such as nerve transmission, muscle contraction, muscle or blood coagulation, glands, nerve secretions, cell divisions. About 99% of the calcium is found in the bones. And the intestinal absorption of calcium is vitamin D dependent. And it does respond to mechanical stress. So the hormone, parathyroid hormone, produced by the parathyroid glands, responds to low blood calcium levels. And so this is going to stimulate the osteoclast to resorb bone. Calcium is released into blood, raising the levels, and PTH secretion stops. This is negative feedback. You also have calcitonin produced by the parafollicular cells of the thyroid gland in response to high calcium levels. So we can have a little relationship here between parathyroid hormone and blood calcium levels. We've got a fulcrum and a balance between calcium homeostasis. We've got falling blood levels and rising blood levels. And so if there is an imbalance, falling blood levels, the thyroid gland is going to release parathyroid hormone, which is going to go into the endocrine system, circulate, reach the osteoclasts and promote osteoclastic degradation of bone matrix, releasing calcium into the blood. This is going to raise calcium back up to its set level and turn off parathyroid hormone. There are other hormones that play, like leptin. It's a hormone released by adipose tissue, and it might work by inhibiting osteoblasts. There's also serotonin, a neurotransmitter for mood and sleep, but it also interferes with osteoblast activity. There is a response to mechanical stress. Bones which are stressed with weight bearing them or muscles on them, there is something called Wolff's Law, which the bones will grow and remodel in response to demands placed on them. So the stress is usually off-center, so bones become bent. The tendons and muscles pull on the bones, so the bones get markings. The diaphysis is thickest where bending stress is the greatest, and the bones can be hollow because compression and tension cancel each other out in the center of the bone. So here we've got some compression of this diaphysis and tension of the diaphysis. You've also got angular stress across the head of the femur with load on the top of the head. So there is twisting and there turning and there bending, and these will all promote bone formation and hardening of this bone. So Wolff's Law explains that handedness, left or right, results in thicker and stronger bones corresponding to the upper limb. Curved bones are thickest where most likely to buckle. Trabeculae form trusses along the lines of the stress. Now, bones of the fetus and people who are bedridden, these are featureless. These bones are smooth, okay, because they don't have things pulling and tugging on them. But if you look at a regular adult, especially an athlete, they're going to have a lot of markings on their bone as a result of Wolff's Law, where there is tension and compression, and this bone is stretched, and therefore these markings are produced. Let's look at bone repair. So fractures or breaks, and during youth, most fractures result from trauma. In old age, most result from the weakness of the bone due to bone thinning. So common types of fractures are non-displaced, so this is the ends retain the normal position, or this displaced, where the ends are out of alignment. There's a complete break, which is a break all the way through, or incomplete break, not all the way through. There is whether skin is penetrated or not. So an open or a compound break is when the skin is penetrated. A closed or a simple break is when the skin is not penetrated. So here we have a spiral fracture. These are common in sports injuries. This is from twisting. We've got a separation of the epiphysis from the diaphysis along the epiphyseal plates. This type of injury can, if it happens in someone who is young, it will stop them from growing on that that knee, and they will have a limp because they will not grow like they should. Let's see. There are depressed fractures, like with the skull, when you get depression of these flat bones. Green stick fractures are incomplete breaks. So it's much of the way like you break a green twig. It doesn't quite break, it bends, but somewhat breaks. And so these are green stick. These are quite common in children. So let's look at repair. So first, after a break, a hematoma forms. And this is from disruption of these blood vessels, and blood starts to pool. Then fibrocartilaginous callus forms, and new blood vessels start to form. And so you get cartilaginous lay down where this hematoma was, and it promotes a lot of new blood vessel formation. Then the spongy bone is laid down, as well as the more cartilaginous bone, and the fracture heals after some remodeling. So the treatment involves reduction, which is a realignment of the broken ends. Closed reduction, the physician will manipulate to correct the position, but an open reduction, the surgical pins and wires secure ends. Immobilization is when traction is needed to heal, where you have to keep the bones at a certain distance apart so that they come together normally. So there are 4 stages to repair. There's the hematoma formation, the fibrous cartilaginous callus formation, the bony callus formation, the bony remodeling. Then we've got hematoma formation, torn blood vessels, as well as fibrocartilaginous callus formation is where the capillaries start growing. You start having phagocytic cells clearing debris. Fibroblasts are going to lay down fresh collagen, create matrix. The osteoblasts are going to create spongy bone, and this is all fibrocartilaginous callus. Okay, fracture treatment and repair. So bony callus formation, within a week the new trabeculae will form, and the callus is converted to bony or hard callus within about 2 months. And then bone remodeling begins during the bony callus formation and continues for several months. Okay, let's look at certain bone disorders. So the imbalance between bone deposition and reabsorption underlie nearly every disease that affects the skeleton. We've got osteomalacia and rickets, and osteoporosis and Paget's disease. So in osteomalacia, the bones are poorly mineralized. The osteoids are produced, but calcium salts are not adequate for deposition. And you get soft, weak bones and pain upon bearing. Rickets is osteomalacia in children, and it results in bowing of the legs and other bone deformations because the bone ends are enlarged and abnormally long. The cause to rickets is vitamin D deficiency or an insufficiency of dietary calcium. Osteoporosis is a group of diseases in which bone reabsorption exceeds deposition. And so the matrix remains normal, but the bone mass declines. And so spongy bone of the spine and the neck of the femur is most susceptible. The vertebra and the hip, those are commonly fractured. So you can see normal bone trabeculae, and then osteoporotic bone. You can see it's got this moth appearance, like moths have eaten it. So the risk factors are age and postmenopausal women. So it affects about 30% of women aged 60 to 70 years and 70% aged about 80. Estrogen plays a role in bone density, so when levels drop at menopause, women run higher risks of developing osteoporosis. Men are less prone to develop osteoporosis because of sustained testosterone in their system. So additional risk factors might be insufficient exercise, poor diet, smoking, genetics, other hormone conditions, and then alcohol consumption. So treating osteoporosis is with calcium, vitamin D supplements, exercises that weight bear, hormone replacement therapy, even though this is controversial because there might be an effect on the cardiovascular system. Okay, other drugs. We've got a number of new drugs that are out that partially reverse osteoporosis. Then there is Paget's disease. This is excessive and haphazard bone deposit and reabsorption cause bone to grow fast and develop poorly. So it's a very high ratio of spongy to compact bone and reduced remineralization. So there's more reabsorption. Usually it occurs in the spine, the pelvis, the femur, or the skull, and it's usually after 40. So the cause is unknown, maybe viral, and the treatments would include calcitonin and bisphosphonates. Okay, almost done. So developmental aspects of bone. So the embryonic skeleton ossifies predictably, so the fetal age is determined from the x-rays and the bone formation. So most long bones ossify by 8 weeks, and the ossification centers develop by 12 weeks. At birth, most long bones are ossified, except for the epiphyses, of course, which stay open until early 20s, late teens. The epiphyseal plates persist through childhood and adolescence. This is where the long bone grows. And at 25, all bones are completely ossified. The epiphyseal plates are sealed, and skeletal growth ceases. In children and adolescents, males tend to have greater mass than females. And that is it. Okay, so I will see you tomorrow for Chapter 7. All right, bye-bye.